Good morning, everybody. I'm seeing all of you are joining just right now. As always, I like to say we're just giving a moment for everybody to join, just literally to kill some time to get everybody in here. We do have a really exciting presentation today by two of our colleagues. So I'm going to turn over to Dr. Dunn. Dr. Dunn, as always, is with us at Grand Rounds, and she has an update for us as well. Thank you very much.
Good morning. Thank you, Dr. Osdaga. First of all, I just want to say I put in the chat the Zoom backgrounds, and I want to give a shout out to the communications team for giving us these wonderful backgrounds from Martin Luther King Jr. Day to Lunar New Year to just our general Celebrate Diversity backgrounds. So they've been doing a fantastic job, and I just want to thank everyone. Next, I want to mention, speaking of backgrounds, Martin Luther King Jr. Day will happen before our next Grand Rounds. So I encourage all of you to investigate all of the incredible events that are happening across the Bay Area. Most of them are free. There are marches, there are train rides, the whole nine. So please check those out. And lastly, we have been discussing the 1619 project, Nicole Hannah-Jones's groundbreaking work. Her podcast is available on Apple or anywhere you get your podcasts. And Dr. Salas and I will be discussing episode 4, which is especially relevant to us in the medical community. It's called How the Bad Blood Started and looks at healthcare and how slavery's legacy affects healthcare then and now. So please join us on Thursday, February 9th at 5 p.m. Dr. Salas has put the registration in the chat. There are also some QR codes on your screen. We hope to see you for what promises to be a fruitful discussion. And this is going to be an online event. So we look forward to seeing you then, February 9th, 5 p.m. to discuss episode 4. Thank you. Back to Dr. Osdaga.
Thank you, Dr. Dunn. Dr. Salas, thank you for sending that link. And Dr. Dunn, thank you for sending the Zoom background links as well. You'll see my background has changed to reflect our upcoming events. And please do always check our Zoom background website. The communications team has done a great job, as Dr. Dunn was mentioning, giving us a bunch of options for Zoom backgrounds. And any other ideas you have, please send to me. I'm happy to see if we can create more. Thank you very much. I just want to briefly mention, Russell, if you go to the next slide, please. Thanks so much. We have our first of hopefully many clinical educator happy hours. And the purpose of this is to share some of the updates that are happening from our leadership, as well as hear from you, as well as just bring many of the clinician educators together to talk. A lot of the things that are going on among clinician educators are very similar amongst all the different departments. So it's an opportunity to really bring people together for free food and drink. So please do join us out the LKSC on the second floor on Monday, February 6th, 4:30 p.m. So hope to see you then. And then we can move to the next slide, please. And just want to mention, next week we have Dr. Bloom as our special lecture. We do the American lecture, professor of Basic Science Division of Computational Biology. So we'll send more information on the details of that lecture upcoming soon. But please do join us as well next week for that special lecture. We'll send more updates about that. With that being said, a special thank you to Dr. Chang, our Division Chief of Primary Medicine, Primary Care and Population Health, for being here to introduce our speakers, Dr. Lin and Dr. Edwards. Again, been looking forward to this for some time. I'll turn over to you next, Dr. Chang. Thanks so much.
Hi, good morning. Thank you so much. It's great to be on this side of the curtain again. Today's Grand Rounds is entitled Storytelling in Medicine, and it's such a pleasure for me to introduce our speakers this morning, both faculty in primary care and population health. You know, except for Abraham, whose new book, The Covenant of Water, is coming out this May, pre-order available, little plug for that. Most of us believe we're really just too busy or maybe not talented enough to engage in medical humanities. You know, and maybe we are, but I once attended a creative writing workshop led by Dr. Edwards. It was at the end of a long work day. I was tired. It was getting dark outside. We were in the Hoover Library, a group of maybe 8 of us, and Dr. Edwards gave us a writing theme, and we wrote for a while and then shared what we wrote with each other. I don't remember exactly what I wrote, but I will never forget how alive I felt, how connected to the meaning and emotional depth of our profession, and how connected I felt to my fellow physicians in the room. That glow stayed with me for days, and years later, it still lingers in my mind. So I'm grateful to our speakers this morning for reminding us of the role medical humanities can play for all of us in enriching our professional lives and for their leadership in creating opportunities for us and our learners. Lauren Edwards, a clinical assistant professor of medicine in the Division of Primary Care and Population Health. She's a primary care internist who practices at Stanford Primary Care Los Altos, where she's also the medical director. She's the course creator and director of creative writing in medicine and narrative oncology, two curricula for Stanford and general medicine residents, supporting physician well-being through writing. She's also the program director for the Stanford Medical Humanities Summer Scholars Program and co-teaches storytelling in medicine, a Stanford sophomore seminar with Dr. Lin. Bryant Lin is a clinical professor of medicine, also in the Division of Primary Care and Population Health. He's also a primary care physician, but an educator and researcher as well. The cornerstone of Dr. Lin's work is keeping medicine focused on humans, patients, providers, families, and trainees, and not lost in technology and algorithms. His research and educational interests span developing and testing novel medical technologies, improving the health of Asian populations with precision and population health, and increasing expression and interconnection in the health community with the humanities and the arts. 4 years ago, he co-founded and currently co-directs with Dr. Lata Palaniappan the Center for Asian Health Research and Education, CARE, which aims to improve the health of Asians everywhere. And last year, he was appointed Director of Medical Humanities and Arts at Stanford, and with Dr. Edwards, teaches the sophomore seminar, Storytelling in Medicine. With that, I will turn it over to Dr. Lin.
Great, thank you so much for that kind introduction, Dr. Chang. So today we're going to talk about storytelling in medicine. No relevant disclosures from either of us. We're going to discuss why storytelling is important in medicine. Talk about defining medical humanities. Discuss the evidence supporting medical humanities work. Go over some research highlights for some ongoing research we have, in particular led by students at Stanford. Talk about current programming within our medical humanities program, also called Medicine in the Muse, and have a brief call to action about how you can join efforts in medical humanities at Stanford. So what way to start out a talk about storytelling in medicine than to share my own story. This is me about circa 2013. I think it was for CV Med. I went and joined a health fair down in the South Bay. I checked my own blood pressure. It was high. You know, I was overweight, bordering and obese. And I was really motivated then to really practice what I preach, eat better, exercise. And, you know, this was the result. 2015, I lost, I think, about 35 pounds at the time. Unfortunately, with the past COVID, I've gained some of that back. But as you know, it's a never-ending battle. But the interesting thing I took away from this was that, you know, by 2013, I'd been at Stanford for 8 years, you know, telling my patients, you know, everything, all the evidence, everything evidence-based, talking about, you know, how they could change their diet, improve their health through diet and exercise. But interestingly, you know, the response may have been tepid because I found out later, after patients saw me having lost weight, they almost all asked me uniformly, how did you do it? How did you lose weight? Even though I've been telling them, you know, and of course finally practiced what I preached, the same thing over years, now they seem to believe it because they saw the proof in my first person story. So, you know, this being grand rounds, let's talk about the evidence. There's not a lot of studies behind this approach. So this is looking at generally first person storytelling on changing health behaviors. So there's a review done recently in 2020. They found 22 studies that met the criteria. Looked mainly, these studies were around cancer, diabetes, hypertension. Found in 6 studies, there was an improvement in attitudes around health in these areas. One study showed an improvement in knowledge, and some showed improvement in health behaviors like quitting smoking and there are 3 that showed improved health outcomes with metrics like A1C. So again, early stages yet for this approach in terms of research, but a lot of promise here, as you can see. Compared to other things we see reviewed in medical grand rounds, this is probably most early in terms of evidence. I wanted to also pick out a specific intervention that was done in 2009. This again is from a great team of researchers that looks at storytelling in medicine and the impact on behaviors and screening. They looked at storytelling approach versus a risk tool approach. So patients were counseled, Latino women were counseled via storytelling or a risk tool to promote colorectal cancer screening. And 78 women were randomized. And the intent to screen was greater after the intervention in the storytelling group, as well as the intent to recommend to other people in the storytelling group as well. So a lot of promise to using this approach. Wanted to add another study, again, from the same group. They looked at a much larger randomized control study looking at storytelling versus didactic learning in a broader effort to counsel about dietary changes in behaviors related to colorectal cancer risk. Unfortunately, this was a big study, and as you know, dietary studies are challenging. There was no difference in main food category changes pre and post intervention. But looking at a sub-analysis, again, there was some evidence of hope that this approach was helpful. There was an increase in fiber once you kind of did a sub-analysis on fiber intake, calcium in vegetables. That did seem to have an impact. This being storytelling in medicine, I've got to share at least 3 stories today. This is a story from my patient, and rather than me tell you his story, so he was around, Charles Betts, unfortunately he's passed away since then, but he was around 100 at the time he told this story. He was a World War II veteran and shot down in the South Pacific. So I apologize for the audio, it's a little bit dim, but you may have to turn your volume up.
That was the reason we got shot down. So we landed in the water, and this one fella, I remember very vividly, but his last name was Priest, Preece, and he went to inflate his life jacket, and he yanked it too fast. He tore the whole front of it off. So he was left without a life jacket. Well, during the time we were in the water, and of course the planes were strafing, I would say this: they were not strafing us in the water. We were already in the water, but we were not the target. They were trying to sink that airplane. We were in the line of fire, of course. And poor old Priest, he was hanging on to one of the floats. He was scared to death, and I don't blame him. Firing at him and no life jacket. So there was a lull in the firing. So I went over and talked to him. And someone said, "Get him off that float." So I went over there. I was the closest one, I guess. And I told him, I said, "Priest, I'm here to help you. Don't grab me." Because I said, if you do, you foul my life jacket up and we won't have any. And he was very, very nice about everything. He did just what I told him to do. So he got off the float and we drifted away from the plane. Well, the plane wasn't sinking that fast. It was sinking, but not that fast. And there was a wind blowing. We had a little wind, and it was blowing. The wind was blowing the plane away from us. So Mr. Ralston, he was the co-pilot. He was right close to us in the water, and he says, "I'm going to make a swim for it." and get that life raft out. And he did. Thank goodness he was a good swimmer, because he swam and got aboard the plane and broke out the life raft. And consequently, that we all got in it. And that's why I'm here today. That was the reason we got.
So he was shot down, was floated on a raft for about 2 weeks before landing in the island and eventually getting rescued. I was just so amazed by his story and learning about him and getting to know him as a person. I personally believe getting to know him as a whole human being was really helpful for me to help with his medical treatment and guidance. He had a daughter, and they came to me in clinic one day, and I said, "What are you doing for your 100th birthday?" So they weren't planning on doing anything in particular, and I felt that was concerning. I thought this gentleman had done so much in his life and deserved to have a better 100th birthday. So in our clinic, we, through some other patients who were Navy recruiters, were able to get people, this group of fine Navy enlisted personnel flown in from around the country because they were recruiters. They could catch rides on Navy planes and attend the birthday to him. And his daughter still come back to me after he passed away saying how much he really appreciated that event. There really wasn't a dry eye in the house. So I was curious, does this help our care of patients? Again, what's the evidence? This is grand rounds. There's actually not a lot of evidence and work in this area. It's called life story work. There was a systematic review done quite a while ago. Nothing since then that I could find. And overall, the work in this area is immature. Recommended more research, and there's a lot of complexity here. But there's some things I feel we don't necessarily need to have evidence behind. That knowing more about the patient's life story, even though it may not be obviously directly related to their medical care, is really, I find, tremendously important. So let's zoom out a little bit, talk about different terms you may have heard. I know a lot of people aren't familiar with medical humanities. There's also health humanities and narrative medicine. So how are these different and the same? Well, the challenge is, I think every organization defines them differently. You can see here, again, the devil's not in the details. I don't put this here for you to read it, but more of just to see that there's a lot of complexity differences in how we define medical humanities. But generally, it's agreed it's an interdisciplinary field involving humanities and the application to health, but there are different perspectives on them, as you can see. There's also pedagogical definitions. This is from AAMC, Journal of the American Association of American Medical Colleges, and then adding a little bit more specificity about how there are certain characteristics that are shared among medical humanities in terms of the teaching perspective. So health humanities is this other term out there, and some institutions use this term in lieu of, instead of, or overlapping with medical humanities. Dr. Paul Crawford out of the University of Nottingham is one of the leaders in this effort, especially internationally, and he refers to it as championing the application of arts and humanities in interdisciplinary research and education and social action to transform health and social care, health or well-being. But you can see again, at BU, the definition has other nuances and other perspectives in there. Again, the devil's not in the details, but more about there's not clearly one consensus definition for what medical humanities or health humanities is. Then this leads to narrative medicine. So narrative medicine is a field, a discipline that was really famously championed by Dr. Rita Sharon out of Columbia. And you can see this again, is this a subpart of medical humanities? How does it overlap? Is this, what's the perspective here? And again, very similarly, she defined this as commitment to understanding patients' lives, caring for the caregivers, and giving voice to suffering. So thought to be more of a subset of the broader medical humanities and health humanities efforts. So I was appointed director of medical humanities a year ago in September. And so what we did was we interviewed over 100, maybe even 200 people in the community at Stanford and the health community to decide how we were going to approach medical humanities and health humanities. And we came up with this mission of empowering people in the health community to enrich their lives and connect to one another using the humanities and arts. And the vision is eventually a world where sharing experiences, knowledge, and wisdom in healthcare is open, clear, and frequent. And our goals are to educate by training the next generation of humanist healthcare providers, enable by providing tools, space for people to express themselves, excite by inspiring the community to create and connect, and expand by increasing the representation of diverse voices in health. This is a framework that Dr. Nguyen and Haidari and several others have contributed to. So if you have thoughts on this framework, it's a work in progress. But framework around, again, storytelling, knowing your own story, like, for example, I told part of my story earlier, knowing the other person's story, maybe it's a doctor-patient, maybe it's a caregiver-patient, maybe it's a family member and the physician. Maybe it's a doctor and a nurse, or APP and a staff member. But knowing the other person's story as well as your story, knowing as best as you can. And also it's around, how do you tell a story? How do you relay information? How do you create human connections? Really, this is all around developing human connection. And as Dr. Cheng mentioned earlier, also around enrichment. And most importantly, we really want to broaden this health medical humanities community. Turn it over to Dr. Edwards.
Hi, thank you so much for having me. I'm so excited to be here. I love getting to talk about medical humanities. And I'm going to start by talking about why we should include medical humanities and art in medical education. And if you think about the strengths of humanities and the arts, then a lot of these potential benefits just make sense conceptually. So humanities can help foster empathy by allowing learners to embody different perspectives. It can support resilience and combat burnout by giving the chance for learners to process difficult situations and reflect. As Dr. Lin pointed out, story is really at the core of taking good care of our patients. The arts often don't have a right answer, and so getting to practice that for learners can allow them to feel more comfort with ambiguity. And as we know in the practice of medicine, ambiguity is highly prevalent. Most medical humanities and art education involves working with teams. It can uniquely support DEI by giving opportunities, again, for multiple perspectives, for modeling, for getting involved in advocacy. There's a particular branch called Critical Medical Humanities at Yale, which is really a call to physicians to participate in health policy and social justice. You might imagine how studying visual arts could help bolster clinical observational skills. And then importantly, the humanities and arts are inclusive of all multidisciplinary team members, patients, families, and caregivers. So though those concepts seem intuitive, I wanted to then review the evidence supporting that. So starting with a very high level view, this was a scoping review of over 800 records and 7 databases in the US and Canada. So it gives sort of a nice sense of the landscape of medical humanities education, called How Are the Arts and Humanities Used in Medical Education? And as you can see, the vast majority of programming is in literature and writing, followed by visual arts, theater and drama, television, music, and then a variety of other media like religion, philosophy, graphic novels, for example. Most of the learners are undergraduates. And then interestingly, only about half of the programs were assessed for outcomes, with the majority of those being qualitative assessments, about a third being both qualitative and quantitative, and a minority being quantitative only, which sort of speaks to some of the controversy of evaluating the outcomes of arts and humanities, sort of a camp that feels like the quantitative assessments will always miss something about the benefits. And another camp that really argues that if you're going to try to argue for time and curriculum, then you really need to speak the same language as medicine and show quantitative benefits. So getting into the details a little bit more, this is a review of 55 unique programs in narrative medicine or writing across the globe, most of them in North America. And they identified some key competencies that were evaluated and shown to be beneficial across all. You can see that most of the studies were qualitative again, and that interestingly, the strongest quantitative benefits were seen in empathy. And then to the next most common type of curricula, that's the visual arts. This was a review. They looked at 70 medical schools and honed in on 11 of the most robust visual arts programs and found 5 key themes and programmatic goals that were evaluated, including clinical observation, empathy, team building, wellness, and cultural sensitivity. The strongest evidence across the programs was for clinical observation. And interestingly, in both reviews, it sort of reflected the heterogeneity of the types of studies that are done on medical education and medical humanities. Most are qualitative. They tend to be feedback-based assessments, a single institution, and really short-term outcomes. So most of the studies include immediate post-evaluation for the outcomes. This was one of the better studies on visual arts in that it was 4 years. So it was looking at longer-term outcomes. It was multi-institution, Cornell and Columbia. It was a mixed method study, and they did use validated surveys to look for reflection skills, personal bias awareness, and tolerance for ambiguity. They did find a statistically significant improvement in reflection scores. And then, as I mentioned, I think a growing avenue for medical humanities education is in advocacy and DEI, and this is a nice example of both. So this is called The Institution Was Never Meant for Me, the Impact of Institutional Historical Portraiture on Medical Students. And essentially it was a questionnaire given to medical students at Yale about how the portraits in the hall of the medical school made them feel. And you might be able to see from the photograph there that they're pretty one-note portraits here. It's mostly older white men. And a few key quotes there on the right. It was 100 years since the first women graduated from here or went here. It's been 100 years and all the pictures on the wall are still men. And I think this is just a space that clearly is not for me. And so most of the quotes were along those lines, and they were able to take the results of that study and advocate for a temporary photography exhibit called Faculty Women in Medicine, and to reevaluate why these portraits are still hanging there. As I mentioned, most studies look at short-term effects, but here's one that looked at the long-term effects. So Yale's had a resident writing workshop annually since 2003, and they took a cohort of 10 years of participants and sent them a survey asking about the workshop's impact on their observation skills, empathy, and writing ability. And so although it was, an opinion-based survey, it's notable that 85% felt that it improved their observation skills and 90% felt that it improved their writing ability. And then I always think it's important to emphasize the inclusion of patients, family members, and caregivers in medical humanities and arts education. On the left is a study across 13 Italian headache centers looking at the use of narratives about the experience of chronic migraine that included patients, caregivers, and their clinicians. And you can see that the vast majority felt that it was a positive and useful experience. And on the right is our colleague, Dr. Hannah Kirsch. She's an attending here in neurocritical care and has a master's in narrative medicine. And she runs several programs that are patient-centered. Most of the patients have had strokes, and they tell stories and write stories about their experience of new deficits, and it includes medical students and residents. And I'll give it back to Dr. Lin. I think you're muted there.
Thank you, Dr. Edwards. I wanted to provide a few research highlights for what we're doing at Stanford in terms of research in the medical humanities and the arts. This is a project which we're calling Project Portrait, led by students and artists. We're providing personalized art sessions. There are two arms. One is a traditional art arm, and one is a generative AI arm. We are at Stanford, after all. Patients undergo an interview discussion with the artist, and the artist will then either work with the patient on developing a traditional art piece of art, artwork, which could be a portrait or something else, or they will work with the patient to input their interests, feelings, thoughts into a generative AI engine to create artwork that way. We're looking at self-reported outcomes and covering pain, boredom, loneliness, stress. Using this as a pilot study to determine effect sizes for a larger study. And we hope this program will be offered long-term via patient experience. And great thanks to the Mission Hospital Medicine for helping us in terms of recruiting patients in particular. So really appreciate their support. And you can see the great list of students here, and as well as Lauren Toomer, who is the lecturer who has a joint appointment in the Department of Art, as well as anatomy, and teaches art and anatomy. This is an example of an artwork, AI generative artwork, developed with one of the patients. Looking for adult patients, they have to be able to participate in an interview and consent, and they have to be inpatient at Stanford. Please contact our research coordinator, Emily Vu, if you have patients you want to refer, or if you're interested in helping out with this research. In terms of the next study, rather than me telling the story, I think best to be heard from Yo-Yo Ma.
Hello, I'm Yo-Yo Ma. When I play this music, it puts me into a special state of mind. And that's what I'd like to talk to you about today. For all of you musicians, performing artists, during this time, you must be thinking to yourselves, as I do myself, what can I do? What's my meaning? What's my purpose? How can I practice my craft and my art form? Well, I'm here to talk to you about a possible way to do that. During the last couple months, I've been working with a group called Project Music Heals Us. The idea of reaching into hospital rooms to reach health workers, patients, some who can talk back, some who can't. But to hear music like this, songs of comfort, is part of the healing process in the midst of worries, inaccessibility to family and friends, all the masks and the fears of getting infected or dying. Music is one of the best medicines one could offer to highly stressed people.
I think you can agree that Yo-Yo Ma tells that story better than me. So Project Music Heals Us reached out to us at Stanford. They've delivered now, I think, over 15,000 virtual concerts to patients since the pandemic started, covered in the New York Times as well. And they were interested in looking at outcomes from their intervention. Of course, when Yo-Yo Ma, performs, the whole hospital stops and no one does anything but listens to the music. So we're doing a very similar protocol. Again, this is led by Project Music Heals Us in collaboration with Stanford, as well as several students, in particular Melanie Ambler, who's really supported this project. We're looking at baseline surveys, self-reported metrics, physiologic measurements, having the intervention of the virtual concert, and then again, repeating or continuously measuring those physiologic measurements and doing post-intervention surveys as well. So if you're interested in this project, please let us know. We're hoping to take the data from this project and apply for a grant from the NIH. NIH, as you may or may not know, has a Sound Health Initiative, so they have grants specifically in this area looking at the impact of music and health. So wanted to talk a little bit about our current programming. We do have, as many of you may know, a scholarly concentration in biomedical ethics and medical humanities. And then Dr. Edwards leads the programs as she will discuss. The concentration is really an amazing concentration, probably one of the few or only ones that is not really primarily driven by hypothesis-driven research, looking at ethics, humanities, and arts, and pretty broad range of projects that are acceptable in this area. Turn it back to Dr. Edwards.
I've been very fortunate to work with the internal medicine residents in this arena for a while. I founded and continue to run 2 curricula for them. One is called Creative Writing in Medicine, and the other is Narrative Oncology. Both are opportunities for the residents to read pieces and reflect on those and write 2 prompts. Narrative Oncology was sort of a natural branching out from the first program because we noticed that so many residents wrote about their experience on their inpatient oncology rotation. So it's pretty unique in that it occurs during an active inpatient rotation. And both give the residents opportunities to reflect on things that are specifically difficult in residency and things that continue to be difficult throughout the practice of medicine. They also give the residents opportunities to support each other as they share their pieces and respond to those. And then particularly the team dynamic on Med 10 is unique in that they're all, an active team taking care of the same patients. And so if a resident writes a piece without naming the patient, every resident knows exactly who they're talking about and can offer support to their teammates. I want to particularly thank Dr. Witalis and all the associate program directors for being supportive of these programs over the years, and to all my team members listed there as well. And we did put out a paper last year about narrative oncology. Part of it was a quantitative study about the impact of the workshops on resident wellness. And part of it was creating an educational framework to be able to implement the curricula at other institutions. This is the quantitative piece. And so you can see we did a control year and used the Physician Wellbeing Index, which is Dr. Shanafelt's index as a marker of wellness. And then we did an intervention year. And during the implementation year, resident burnout was similar in the initial weeks, but it didn't rise as much by the end of the rotation in the implementation year. But I think the most important thing that comes out of these medical humanities education curricula is actually what the learners create. And so with permission, I wanted to share a couple of pieces by the residents. The first is a poem. I get a call from the ED. This was as complicated as cancer patients can be. This man with daughter at bedside, feeling weak, dizzy, but clinging to hope. A terminal this poor man had. Glioblastoma, the worst prognosis to any man. With this knowledge, I ventured in and letting them know of the possible end. Nothing could be done. The tumor is too advanced. The symptoms are worse. Little is the time they had. Tears flowed like a constant stream. Hope fled away hopelessly. All I could do is sit and listen and guide this man to his final rest with no regrets, with tears running down my cheeks. I think that's a beautiful illustration of the experience of the residents and also just deep empathy for this patient. And the next is a short prose piece called View from Bed by Dr. Nancy Liu. She's a current R3 who will be joining the faculty as a hospitalist shortly. And we often ask the residents to try to write from a different perspective. So I think this is a nice example of that. I wish they would ask me if I'm ready to die. I don't know what I would say, and I'm not sure how to say it, but I know that every day I nod my head along to words I don't understand, to words that I question are really even words. I shuffle along this corridor to yet another blood draw, to a scan, but really to what? I want them to tell me where we're going. Will I see my grandchildren graduate college? Would I see them graduate even if I didn't have this hidden sore that breathes and grows inside me? Will I have another night with my wife? Will I be able to watch my favorite show in my favorite chair and fall asleep to buzzing fanfare about a new electric fryer that can bake chicken nuggets in 2 minutes? God, I love that. And so next I wanted to highlight a couple of our summer programs. The first is Art and Anatomy with Lauren Toomer, which Dr. Lynn mentioned. Lauren is a visual artist with a joint appointment in the art department and anatomy department. She works frequently with the medical students here, but this is her summer program aimed at high school students. It's a 2-week program. And on the right, you can see some artwork that her students from last summer created. And then next is our Summer Scholars Program. This is an 8-week immersive virtual course that's aimed at undergraduates and graduate students. It's meant to be an introduction to the full breadth of medical humanities. So we have expert speakers in sort of all media and genres and faculty mentorship to create a final project. And then finally is our Storytelling in Medicine course. This is a sophomore seminar that at Stanford that Dr. Lynn and I co-teach together. Similar in structure to the Summer Scholars in that it's an introduction to the breadth of medical humanities, and the students are supported to create a final longitudinal project. This is an example of one of the students' final projects called Do No Harm, a visual art installation by Grace Adebogan. It's meant to be a reflection on 3 key issues for Black women intersecting with medicine. On the left is the stigma of mental health. In the center is the need for more Black female physicians. And on the right is representing the increased postpartum mortality rate for Black women in America. It's really a beautiful piece that then went on to be presented at the Medicine and the Muse Symposium. So finally, we have a call for action, or just ways that you could be, if you're interested, you could participate in medical humanities and arts here at Stanford. The first is, along with Dr. Malathi Srinivasan, we've created a clinical educator medical humanities scholars program. So that's aimed at introducing medical humanities to clinical educators and supporting pieces to publication that should be launching in the fall. We do have a faculty student mixer coming soon, so please stay tuned for the details about that. If you have high school students that might be interested in the art and anatomy program, or undergraduate and graduate students interested in summer scholars, those applications are still open. And then Dr. Lin mentioned the couple of research projects that we're still looking for participation. So thank you so much.
Thank you, Dr. Edwards. I was remiss in forgetting to add a call to request. If you are a musician or a singer, or you play an instrument or you sing, we also have started the Stanford Medicine Orchestra and Stanford Medicine Chorus, and they had a fantastic concert last fall. There was really not enough time today to talk about how many wonderful programs we have, so we've definitely tried to cherry pick here. But if you have any ideas or thoughts or suggestions for new programming, educational opportunities, research, please let us know.
Thank you, Doctors Edward and Dr. Lin. I am always impressed by the number of the amount of talent we have in our community, among physicians, through medicine, art, and all the different things. And so much thanks to the programs that you both have been involved with since before the pandemic, but certainly since the pandemic as well, when we needed it more than ever. I just want to say a special thank you to you both. I knew I was excited about this presentation, and after watching it, I got to get a better sense of why. I've always thought our primary care doctors are some of the best when it comes to really connecting with our patients and really looking at ways to help engage them, and as well as our colleagues. And the work you guys do, our leaders in this field, is really a reasons why. So thank you so much for being here today presenting and for sharing all the amazing work that you do. And I know Dr. Chang is super proud of all the work that you both do. So thank you so much. He's raising his hand right there. If anybody back here has any comments, please welcome to. But I want to do, there's a few comments here, questions I'll get to first. Dr. Ash says, as an editor for the General Medicine Journal of General Internal Medicine, even this is a shameless plug, Dr. Sharon, Rita Sharon, one of our associate editors as well with him, we encourage medical humanities submissions. What advice do you have for faculty and trainees wanting to publish their reflections?
I think that's great. That was part of the reason Dr. Edwards and Dr. Srinivasan came up with this CE workshop. So we didn't plant the question from Dr. Ash. That the goal of that is that they've been talking with the CE promotions committee and so forth, and seeing what kinds of things would be good to help support promotion and career development, and publishing these kind of perspective reflection pieces still counts. They're publications. They can have you contribute to your regional and national recognition. So we encourage you to work with Dr. Edwards and Dr. Srinivasan on the workshop that they are planning. Also, we're trying to create more spaces for people to publish. So we have a Substack newsletter that we started called Panacea Health. So if you want to submit to that, let me know. But I'll turn it over to Dr. Edwards.
Yeah, I agree with all of that. And then I was just going to say that Jim Kahn, who has had many pieces published in Piece of My Mind, he told me every pot has a lid, and that always sort of sticks with me. So it's sort of, finding the right fit for the piece that you want to tell, and don't get discouraged if the first place wasn't the right fit. And so also the Medicine in the Muse website has a list of common places that accept humanities submission. So that's always a good place to start.
Oh, and I forgot to mention Dr. Laurel Breitman has also been very kind. I know she's been a little bit time limited. She's our director of writing, but she's been also very helpful in helping shepherd and mentor people to get their pieces published.
Excellent. A couple of quick things I just want to mention. So Dr. Srinivasan Malathi mentioning the Dance and Medicine Committee is also recruiting participants, patient-facing programs and wellness programs as well. If there's also a request for example, I think, Brian, you're typing right now the post-research link. Any links you want us to share at the follow-up email too, we can send out with links as well. So happy to do that.
Yeah, we'll try to put things on the medmuse.stanford.edu website. Not all of this is up to date, and we'll also put the contact for the chorus. We've got two great people leading our orchestra and chorus. The chorus director is a PhD student in neuroscience, Min Sun Choi. So fantastic. And Jonathan Park and Terrence Yan are two of the conductors for the orchestra. Jonathan is an undergraduate, believe it or not, and Terrence is a community member who works at Apple.
Oh, wonderful. I get a great question here from Dr. Osterberg. Can you comment on the benefits of awe and humanities? There has been considerable work in the experience of awe in nature and its benefits to wellness and prevention and burnout. The effect of awe with humanities can have a similar effect on us, as I feel Yo-Yo Ma just had on us. Couldn't agree with that more. Dr. Kim, Yoon Kim is also mentioning she thinks NPR just had an interview on awe in medicine.
Dr. Edwards, you want to take that one first?
Yeah, I'm not as familiar with the data on awe, but I can imagine that the humanities just has an ability to tap into emotion, and what I observe on the resident programs is just it has an ability to do that with immediacy that just sort of discussing the issues isn't able to achieve. So that certainly makes sense to me. I'm not quite as familiar with the data behind it. I don't know if you are, Bryant.
No, I think it's great. It's a great area. I'm not that familiar with the specific research in this area with awe, but I agree. This is my cheat way of getting people to enjoy the talk is to include Yo-Yo Ma. So that was my cheating there.
Dr. Peterson, what is the content info for Stanford Medicine Chorus? Another one I think people would love to hear. Also, are you looking for musicians in the community for Project Music Heals?
Yeah, so if you go to pmhu.org, so they are a nonprofit organization looking for support. I'm sure they're looking for more musicians. They have a fairly high bar for what they're looking for in terms of kind of professional level musicians, because they are generally a group of professional musicians. So yeah, please check out the website to see. And then if you email Christy Hartman, HART, I'll put it in the chat. She is our program coordinator. She can connect all of you to the relevant programs that you may be interested. So I'll put her email in the chat right now.
There's one last question before I turn over to Dr. Chang. Dr. Linda Cleaver asks about you can see the spelling of it. I wonder if you might measure PNS stimulation by medical humanities activities, and just thank you for your work.
Yeah, I think that's great. For the NIH grant, they are really, very interested in mechanisms, how to, in this case, music, but, broadly from our standpoint, humanities and arts, how do they mechanistically impact our health? And again, very early stages, PNS, peripheral nervous stimulation, autonomic, metrics, autonomic stimulation, vibration, heart rate variability, cortisol levels, lots of things are being looked at. So as you can tell, it's early days in terms of research and in terms of the mechanistic impact of humanities and arts on health outcomes.
I want to thank Dr. Edwards and Dr. Lin, and I'm going to turn it over to Dr. Chang to close this out.
Oh, thanks so much. Just a final comment to thank and congratulate both Lauren and Brian for a wonderful presentation, and more importantly, for carrying the torch on behalf of all of us for the medical humanities. I think in the face of increasing burnout that we're all struggling with, medical humanities is an extraordinarily effective antidote to that. And so I thank you for your work, and I thank our audience for your interest and attention.
Thank you again, Dr. Chang. Thank you, everybody, for being with us today, and we hope you have a great rest of the week, and we'll see you next week. Thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.